Good morning, everyone. Today I'll be talking about Burkitt's lymphoma. Dennis Burkitt was the physician scientist who first identified a distinct geographical pattern in distribution of lymphoma cases in Africa. He called it the lymphoma belt, that later on to the suggestion of an association between this uh, lymphoma and malaria, and it was seen in children. This was a belt across Africa, and it was called lymphoma belt. He soon realized that this unique tumor would reoccur after surgery, and in those days, radiation was not available in Africa, and only chemotherapy was available. In addition, since most of the patients would disappear into the bushes if they recovered, he pioneered short, intensive schedules. This has become one of the most important principles of treating Burkitt's in the modern day protocols. So this was the first article that was published in 1958 in British Journal of Surgery. So I'll discuss the topic under the following heading, epidemiology, pathogenesis, pathology, clinical presentation, and how to approach to a case of Burkitt's lymphoma and treatment options. We will be talking about survival rates of almost 100% today. So Burkitt's lymphoma is an aggressive B-cell NHL of germinal center origin. It is one of the most rapidly proliferating tumor with a doubling time of 24 hours. The hallmark is the presence of MYC translocation. The most common is 8 and 814. There are 3 subtypes that are identified that have overlapping clinical features and pathological findings. So Burkitt's lymphoma with 11q aberration is the new addition to the 2016 classification. So as we all know, the subtypes of Burkitt's lymphoma, we'll talk about each one of them. Coming to the endemic variant, which is seen in malaria endemic region of Africa, typically present as a jaw tumor in the children. Almost all cases are associated with EBV infection, and though MYC translocation is seen in almost 100% cases, it is associated with other mutations also. Immunodeficiency associated Burkitt's lymphoma is typically seen in HIV positive patients with irrespective of the CD4 count, and these patients, they present with usually present with abdominal nodal disease, and also with advanced stage with extensive marrow involvement. And EBV association is around 40% in these cases. Sporadic variant is less common, but we typically see in our clinics also. They present with abdominal disease, and EBV here also is around 40%. So the new entity, Burkitt's lymphoma with 11q aberration, is the so it has been recently recognized in 2016 WHO classification, and it has similar presentation and similar outcomes to the treatments also, but they are MYC negative. Coming to the pathology, so Burkitt's lymphoma is comprised of medium-sized atypical lymphoid cells that grow in a monotonous pattern with the high nuclear to cytoplasmic ratio with round nucleoli. It contains dispersed chromatin in which multiple nucleoli are visible. As you see in the picture, there's a big nucleus and the cytoplasm and a rim of cytoplasm. And in this cytoplasm, it is deeply basophilic and it contains lipid-laden vacuoles. There are sheets, sheets of atypical lymphoid cells give a moth-eaten appearance on a low-power microscope. And the starry sky appearance is due to the high rate of proliferation and apoptotic cell death. These get ingested by the benign macrophages that are seen scattered under the microscope. So to summarize the morphological features of Burkitt's lymphoma cells, it is medium to intermediate sized matured B cells. The nucleus is round, it is non-cleaved, and there are multiple nucleoli that are seen with a very fine granular chromatin. The cytoplasm is basophilic, and there are lipid-laden vacuoles. Absence of TDT and CD4 makes it a mature B cell, and it expresses B cell markers like 19, 20, 22, surface immunoglobulin M. So expression of CD10 and BCL6 makes it reflects their germinal center origin. So coming to the differential diagnosis of Burkitt's lymphoma, and it's so when we consider a high-grade B-cell lymphoma, we have to consider Burkitt's lymphoma as well as the other entities of high-grade lymphoma. So if the tumor has a blastic appearance on morphology, two markers that are essential is TDT and cyclin D1. If TDT comes positive, it becomes LBL, and if TDT is negative and cyclin D1 comes positive, makes it mantle cell lymphoma. If TDT and cyclin D1 are both negative, then we have to consider other three entities, which are Burkitt's lymphoma, DLBCL, and high-grade B-cell lymphoma with rearrangements, that is double hit or triple hit lymphomas. So, when we compare Burkitt's lymphoma with DLBCL and with other high-grade B-cell lymphoma, the cells of Burkitt's lymphoma are small and medium-sized and monomorphic with high proliferative index, whereas the cells of the other two entities are where the proliferative index it is. Proliferative index is variable and the cells are larger. On IHCs, all three entities, they express B-cell markers such as 19, 20, 22, while Burkitt's, it always express so germinal center markers such as CD10 and BCL6, and BCL2 is never expressed in Burkitt's lymphoma. The germinal center markers in DLBCL and other high-grade lymphomas are variable, and they may or may not express BCL2. On cytogenetic testing, Burkitt's lymphoma carries MYC translocation, usually in the form of 814, and also rarely we see 28 or 822. Important to remember that there is no characteristic abnormality to define other high-grade B-cell lymphomas. So pathogenesis, coming to the pathogenesis of Burkitt's lymphoma, the hallmark of Burkitt's lymphoma is the translocation of c-MYC, usually with the IGH gene, commonly known as 814, leading to its uncontrolled activation of genes. The somatic hypermutation and immunoglobulin gene rearrangement is a normal event in a B cell exposed to the antigen. So there is a chance that an error can happen during the gene rearrangement. So why does a c-MYC translocation happens in the first place? One of the hypotheses is that an infection such as EBV or malaria in African endemic regions immortalizes the B cell, and therefore it increases the chances of translocations, therefore Burkitt's lymphoma. The breakpoint region of the c-MYC is not constant, and it is in addition to 814. There could be other partners, as we all already have spoken about. So up to 15% cases can have 812, or just 5% of 2-8 translocation. Since the breakpoint region is inconsistent, the PCR techniques are difficult to establish the diagnosis. The best molecular technique under these circumstances is FISH. c-MYC is a transcription factor, and it forms heterodimers with other molecules such as MAX, and it leads to activation of several genes. On the other hand, MAX can form homodimers or form complexes with MAD molecules, and these entities normally inhibits the transcription. But in Burkitt's lymphoma, the level of c-MYC it far exceeds that of MAD. So therefore, So it preferentially forms a bond with MAX and leading to continuous activation of the genes. So there are multiple downstream actions of overactive c-Myc. This includes proliferation of cells, improved ability to survive in anaerobic conditions, to immortalize the cell by impaired apoptosis, and it escapes the immune surveillance. In addition to c-Myc, other mutations are identified in Burkitt's lymphoma, which can contribute to the pathogenesis, such as TCF3 mutation, that is important for B cell differentiation. Coming to clinical presentation of Burkitt's lymphoma. It differs according to the subtype. The endemic Burkitt's, it is usually seen in children with facial and jaw rapidly growing mass. Sporadic and immunocompromised Burkitt's lymphoma is usually abdominal or ileocecal region. CNS involvement, marrow involvement is seen in advanced cases, and we also see leukemic presentation of Burkitt's lymphoma, or which we call as Burkitt's leukemia. Other sites in the body, like kidneys, gonads, mesentery, RP node, eye, can be involved with Burkitt's lymphoma. So how do we work up the case when the patient comes to the OPD or casualty? First is CBC and manual differential count to look for hemoglobin, platelet, WBC count, or leukemic variant of Burkitt's, leukemic presentation of Burkitt's lymphoma with blasts in the peripheral blood. So LDH, as we all know, that Burkitt's is highly proliferative. So LDH are usually in thousands. And since they are highly proliferative, there is high risk of TLS. So we need to monitor RFTs, LFTs, electrolyte, calcium, phosphorus. So biopsy is mandatory for tissue diagnosis, except in the leukemic presentation, where you can send flow and cytogenetics and get the diagnosis. PET-CT, bone marrow aspiration and biopsy, and CSF studies are important for staging and prognostication. So now coming to the treatment of Burkitt's lymphoma. Since Burkitt lymphoma, it is an aggressive cancer, the approach usually in 80s, 70s and 80s was giving ALL-like regimen, which were usually long. It was just like a BFM 90, which goes on for 6-8 months. So what happened that, however, there were multiple frequent interruptions which were happening and which led to relapse of Burkitt's lymphoma and poor outcomes. So short, intense protocols were developed to treat Burkitt's lymphoma. So there are several key principles that are common to the protocols used in Burkitt's lymphoma. In this slide, we have summarized the principles. And so prompt institution of therapy is important in Burkitt's lymphoma. As soon as the patient comes to the OPD, the diagnosis, whenever it is suspected, the diagnosis has to be made as soon as possible, and institution of therapy like pre-phase should be started. Those intensive approaches and alternate cycles of non-cross-resistant agents are the principles of the protocols, which we will see in further few slides. And since we know that CNS involvement is seen in Burkitt's lymphoma, or these patients can have a CNS relapse, so CNS prophylaxis is important. TLS is very important. So prephase, as soon as the prephase is given, the patient can have severe, moderate to severe TLS, and here stringent TLS monitoring and measures are very important. So as we know that Burkitt's lymphoma, they usually present in advanced stage and poor GC. So, and these all these protocols, they are quite intense. So supportive care of these patients is very, very important for good outcomes. So several groups have developed their own protocols based on these principles, and there are no randomized trials in this setting. So in adult patient, the largest data it comes from German GMOL protocols, and the focus is to reduce the toxicity while preserving the efficacy. So these are the protocols. If we see the EFS is almost same in amongst all the protocols. It is around 60 to 90%. But okay. But we can see in this slide that the toxicities are very common and very high in with these protocols. Around so febrile neutropenia and sepsis is very commonly seen and are major concerns. So the treatment-related mortality is also very high with these protocols. So we must try to use protocols that are very not very toxic. So coming to our favorite protocol, RGMOL protocol in Burkitt's lymphoma, we'll discuss about its data. So previous GMOL and BFM group protocol used methotrexate at almost 5 gram per meter square, which had higher toxicities. And this is a single arm study that tried to improve by reducing the dose of methotrexate to 1.5 gram per meter square and also incorporated rituximab. The study was conducted on 363 patients with Burkitt's lymphoma and leukemia. They reported excellent outcomes of around 5-year PFS of 75% and OS of around 80%. So patients with age less than 55 years had superior PFS of around 90%, while the patients with more than 55 years had inferior outcomes with a 5-year PFS of 60%. So this is the study protocol, and it comprises of pre-phase followed by alternate course of regimen A, B, and C. The treatment is risk stratified, with low risk patients being treated with 4 cycles alone, plus 2 cycles of rituximab. And high risk patients, they received 6 cycles of chemotherapy plus 2 additional doses of rituximab. Use of radiation was optional and we never used it in our practice. And one thing to note was the elderly patients, they received methotrexate at only 500 mg per meter square. So since we don't have access to Vindesin and teniposide, we use alternate blocks of A and B, and we omit C in our clinical practice. So after knowing all these short intense protocols, which were famous in Burkitt's lymphoma, Dunleavy et al. Came up with a new strategy of low intensity but continuous infusion of therapeutic agents such as vincristine, doxorubicin, etoposide, which had shown better cell kill in vitro. The first breakthrough was promising activity that was seen in HIV positive lymphomas with R-EPOCH regimen. More recently, there has been a data of its use even in seronegative patients. And one of the biggest advantage of this regimen is the reduced incidence of toxicities and ability to deliver it in a presence of effusions where high dose methotrexate we cannot use. So there we can use R-EPOCH quite easily. The first publication was this small series that was published in NHM from NIH. 19 HIV negative and 11 immunocompromised patients, mainly HIV positive, and there were 2 patients of primary immune deficiency patients were treated with EPOCH regimen. The HIV positive patients, they received a short course RR EPOCH, which so in this 3 cycles of EPOCH with each cycle containing 2 rituximab was given in HIV positive, and HIV negative patients received R-EPOCH regimen. So the protocol led to impressive responses and lesser toxicities. So the freedom from progression in dose-adjusted epoch R was 95%, and short course RR epoch it was 100%. The overall survival was 190%. The toxicities were not very high and were easily managed. Interesting to note is that the median cumulative dose of doxorubicin and etoposide and cyclophosphamide is 47 to 57% lower in short course RR epoch as compared to dose adjusted R epoch. So in short course RR epoch, we use only 3 cycles, whereas in dose adjusted R epoch, we use 6 cycles. So the median cumulative dose was quite low. And when compared with the simulated bolus administration schedule, it led to transient high peak concentration. The bolus administration had transient high peak concentration, whereas the infusion, it led to extended exposure to steady state concentration, which was the principle of epoch regimen, and it proved that it was efficacious. Subsequently, a study with a larger cohort was published. 113 patients were enrolled, of whom a quarter were HIV positive. The patients were risk stratified based on the stage of the disease, age of the patient, LDH, and tumor burden. So in low-risk patients, short course RR epoch strategy was used, and in high-risk patient, dose-adjusted R epoch with ITMTX was given. So to note that low-risk patients did not receive any CNS prophylaxis. So after 2 cycles of short course R epoch, PET scan was done for response assessment. If the patient was negative, the patient received 1 cycle of short course R epoch and the treatment was stopped. If the PET was still positive, he was changed to dose adjusted R epoch for 4 cycles with IT-MTX. In these patients, the median age was 49 years and the marrow and CSF involvement was seen in 25%. This study again demonstrated excellent 5-year EFS and overall survival with 82% EFS and in high risk patients, and 100% in a low risk patient with manageable toxicities. And CNS involvement was the most adverse factor for this overall survival, whereas HIV co-infection or IPI, it did not affect any effect on the survival, and there was no significant difference in the EFS between interim PET positive or negative patients. So coming to the real world data of Burkitt's lymphoma, this is the data from across 30 US centers. A total of 641 patients were evaluated and who were treated with multiple protocols like CODOX, hyper-CVAD, or dose-adjusted epoch. And so several prognostic factors were identified, mainly age, performance status, CNS involvement, and LDH more than 5 times were the adverse effects, while placement of place of therapy, whether it was academic or a community-based treatment, achievement of CR or advanced age also made some impact on the survival. So 3-year PFS was 64% and overall survival was 70% in real world. And there was no difference in outcome irrespective of the regimen that was used in Burkitt's lymphoma. So coming to the end, relapsed Burkitt lymphoma, though we are talking about 80-90% survival, there is a chance that these patients may have a relapse. And but the outcomes are quite dismal, and getting the patient into the second remission is a challenge. And there is a limited data about the value of transplant in this setting, and novel drugs, they are being used to improve the outcomes. Even if the patient goes into remission after getting a transplant, on an average it was 40% overall survival, which were seen in the chemo sensitive patient. In chemo resistant patient, it was less than 10%. So Burkitt's lymphoma is a rare but highly curable disease, and so rapid diagnosis and early treatment is important. Treat every case as a medical emergency, and attention is to be paid to the supportive care. Use regimen that are effective but are less toxic, and risk-based approach should be used in the clinic. Like low risk can receive 4 cycles versus high risk can receive 6 cycles, and more data is needed for epoch-like regimen, because the data that we have presented, the number of patients are quite low, and there are few concerns about epoch, that how do they address CNS positive patients, and so it needs more evaluation, and more data needs to come out. Plus, there is a new study which is coming up. It is a randomized trial between dose-adjusted R-epoch versus Codox regimen. So whenever it comes out, we'll get to know the data. Thank you. Are there any questions?
Yeah, Dr. Jayashraa, hi. In a resource-constrained setting, how would you manage an elderly Burkitt's?
So, as in if
elderly above 70, I know it's not a common age group, but they have been in there, and they've not. It's not common way of presentation, but it is a practical problem we've seen rarely. How would you manage that, or which regimen would you advise?
So now we need to see if the patient is fit for any kind of therapy first. How's the GC of the patient? If the patient is fit and the GC is okay, there are actually, I could think of 2 regimens. One is giving R-epoch if the GC is okay and patient can tolerate. Second is as in RGMOL protocol, they have given methotrexate at 500 mg per meter square, and as in we can try RGMOL with methotrexate of 500 mg per meter square. So yeah, rarely we deal with such patients, but obviously, as in if the patient is fit, you can treat with either R-epoch or RGMOL with methotrexate less than, as in 500 mg per meter square. That would be my answer. If anyone wants to add to this. Hasmukh sir, Linkrat sir, Manjuman.
As Jayashraa said, that we, obviously using high-dose methotrexate-based regimens or, multi-agent chemotherapy becomes difficult. So RG-mol delivery or regimen similar to RG-mol becomes challenging. So invariably, we end up using our epoch, dose-adjusted R-epoch. Having said that, even then, maintaining dose intensity or, ability to escalate dose becomes challenging in more than 70 years. So that's a difficulty, but yes, if the patient is fit, has otherwise good cardiac function, no other comorbidities, answer is that we try using dose-adjusted R-epoch, not short course R-epoch. Dose-adjusted R-epoch is what we would suggest.
So Amit has asked any treatment option for patients who are not in CR or a relapse case. So, problem is if the patient comes back with a relapse after regimens like RG-MOL and R-EPOC, there are not many salvage therapy options that are available. Though you can give R-GDP, RIs or RIs, but as in these cases are very they have very poor outcome and very difficult to treat. Even though they go into remission, they'll have to do autologous stem cell transplant as soon as possible. But the data is very less and scarce in this setting, and yeah, they are very difficult to treat patients. So then Akhil has asked, at this time point with available data, whom do we give R-EPOC and whom do we give RG-MOL? So basically, first thing we need to see is how old the patient is, how's the GC, does he have effusions? If the patient is on the older side, as in if the patient is above 45 or so, and 40 and has effusion, so straight away R-EPOC. If the patient is younger and fitter without any effusions, we can give RG-MOL.
So just to add to what Jayashraa said regarding how to select, definitely effusion becomes a challenge if because giving methotrexate, high dose methotrexate is a difficult proposition there if you have underlying effusion, pleural effusion or ascites, and many patients do present either because of disease per se or because of hypoalbuminemia. That's one setting. The second important thing is that if you look at the R-EPOC data, you have those patients who are high risk, especially if they have CSF involvement at baseline or if they have bone marrow involvement, they do poorly. So for these high risk patients, it's preferable if there is no effusion to consider starting with RG-MOL, or if there is effusion, you may want to give first cycle as dose-adjusted R-EPOC. And if there is response, then in that case, you can, the effusion disappears, then you can change over to RG-MOL. And another point regarding that relapse, what we were talking about. So relapses beyond 6 months in Burkitt lymphoma are rare. If you look at the induction failure or the initial response, if you give, first line therapy, those who fail to show response is also less. But yes, that constitutes roughly around 10 to 15% of patients. If there is progression on something like R-EPOC based therapy, you can think of switching over to high dose methotrexate based, short course alternative therapy, the basic principle of Burkitt. But the response is those who fail first line therapy or progress on first line therapy are very, very poor. And practically none of the existing salvage options are effective there. So if you fail first line therapy, especially if it's high dose methotrexate based RG-MOL like or Codox MI-VAC kind of therapy, the responses are extremely poor, and effectively it becomes palliation.
So Akhil has asked, doesn't R-EPOC go against the principle? It is short course, intensive, non-cross-resistant, and alternating chemotherapy. So that is what I had mentioned in the slides, that yes, as in the principle is giving cross-resistant and short course, intensive, alternating kind of chemotherapy cycles. Though short course, it has shown as in the infusions they are maintaining the dose level. So what is EPOC principle that gives slow infusions over a longer period of time, which maintains the dose level above the required dose that is effective in Burkitt's lymphoma. So it has worked. Now, only thing is a larger data is required for R-EPOC also. But we see in our clinical practice also it does work in our patients. Ma'am, anything to add on this?
No, nothing. It's again, the same thing that you are looking at, that the doubling time is 24 hours. So you want to maintain the effective concentration for entire duration of that, replication, and use it as soon as your blood counts recover. You want to start the next cycle. So there shouldn't be unnecessary delays, and you're using it for 24 hours. So 24 by 4, 24 into 4 days. And the basis, as Jayashraa explained, that if you have a prolonged continuous exposure of the tumor cells by these plant-derived chemotherapy agents, the tumor resistance is low. So it overcomes the tumor resistance, and you're maintaining the effective concentration for 96 hours. So you're able to handle malignancy, which has a shorter doubling time, meaning the doubling time of 24 hours. So that's probably the reason why it works in DLBCL. If you're thinking in terms of seropositive DLBCL, the same principle applies there. If you're thinking in terms of Burkitt's lymphoma, the same principle applies here too.
Ma'am, I want to make it. Hello, am I audible?
Yeah, Lingaraj, you're audible.
Yes. Regarding that question of REPOC and RGMOL, as you rightly said, there are concerns in high-risk patients, the marrow and CSF involved disease. And one thing to look at is that if you see that REPOC data, almost at least 40 to 50%, if I remember correctly, have normal LDH. How often we see Burkitt with normal LDH in our country? So it's very rare. So that data was based on a very selected group of patients. We need some real world data of REPOC in seronegative Burkitt's to say that that kind of 70% outcome with REPOC is seen in real world also. So this year in Blood Advance, there is a paper. It's a real world data of seropositive Burkitt lymphoma, HIV positive REPOC. The outcomes are 50%, and the trial data is 70%. So there is a concern there that REPOC may not be useful in all comers Burkitt. It may be in a selective group, and definitely if there is high risk, we have to be careful using REPOC in this group of patients. And the randomized study is anyway ongoing. What Jayashraa has mentioned, that REPOC versus Codex MBAC, and that may answer the question in future.
So to answer Dr. Akhil's question on data of short course RR-EPOC, as far as I remember, so we have a seropositive DLBCL short course RR-EPOC data, and it is around 60% in our patients who usually present with advanced disease and with very poor GC. So the outcomes are still good, around 60%. But that is DLBCL as a whole. So now the next question is any difference in treatment with leukemic presentation. So there is no difference in treatment with leukemic presentation. We treat with the same protocols, either RGMOL or dose-adjusted REPOC, and they respond well to the therapy, just like any other Burkitt's lymphoma. So the only concern with leukemic presentation is that they have prolonged cytopenias once you give the therapy. And during that time, the toxicities are more, chances of sepsis are more. So supportive care is really required in these kind of patients. Any other question from anyone?
Any more questions are there?
Doesn't think so.
Thank you, Dr. Jayashraa. Thank you for the nice presentation.